Let's talk lungs with Trent and Lori from Lung Saskatchewan. Dedicated to connecting you with lung health experts and key opinion leaders that will help you transform your care and practice with current, evidence-based lung health information. This podcast is recorded on Treaty 6 territory, the ancestral and traditional territory of the Cree, Dene, Blackfoot, Saulteaux, Nakota Sioux, as well as the territory of the Métis.
On this episode, we are delighted to be speaking with Dr. Shane Shapera. Dr. Shapera is the director of the Interstitial Lung Diseases Program at the Toronto General Hospital. He also works with the Toronto Lung Transplant Program, providing pre-lung transplant assessments for patients with interstitial lung diseases.
Today's episode is sponsored by Boehringer Ingelheim, a global healthcare company working on breakthrough therapies that transform lives today and for generations to come. As a leading research-driven biopharmaceutical company, the company creates value through innovation in areas of high unmet medical need. Thank you, Boehringer Ingelheim.
Welcome, and thanks so much for joining us today, Dr. Shapera.
Well, thank you very much for having me.
Well, Dr. Shapera, we're going to get right into things, and let's start by having you tell us a little bit more about yourself and the specialty that you work in. Why did you choose interstitial lung diseases as a specialty?
Yeah, so I guess I'll start with who I am. So as was said in our lovely introduction, I'm an associate professor at U of T, and I'm a clinician teacher, and I run our ILD group. So there's 5 of us in the program, and we're one of the largest ILD programs in Canada. We see about 300 new patients and about 1,500 follow-up patients with ILD per year. And I guess, the reason I decided to start doing ILD was mostly because it was hard. When I was a resident and I was going through my training, ILD was really the new frontier. CT scans were around, but more and more patients were having CT scans, and we were kind of figuring out what these ILDs were and how to diagnose and treat them. And so it really felt like the most exciting area of respiratory medicine for me. I think it was also the diagnostic challenge that's in ILD. There's no one test that gives you an answer of what's going on. So I really liked, it was almost like the real life version of being Dr. House on that old TV show.
Mm-hmm. Now, for those of us that might not know about interstitial lung diseases or ILD, how commonly is this occurring globally and in Canada in particular?
Yeah, so I think first we sort of have to make sure we're all on the same page about what ILDs are. And so when I'm talking to my patients, the best way I describe it is that if you use the analogy of a building where you've got, the hallways or the airways, the pipes or the blood vessels, the interstitium is sort of the girders, like the part that holds the whole structure together. And these ILDs are where you get either inflammation or scarring along that sort of infrastructure of the lungs. And no one knows exactly what the incidence and prevalence is in Canada because we struggle with a lot of patients that probably fly under the radar. But there have been several estimates that think that about 15,000 people in Canada have idiopathic pulmonary fibrosis. That's the most common disease that we'll see in our clinic. And if we take all the different ILDs, that's probably somewhere around 50 to 60,000 Canadians. One of the things that's really important to remember, though, about ILD is that it's getting more common. So this is a disease that happens in older patients. So we would expect it to become more common as the Canadian population gets older. But what we're seeing is that rates of ILD are going up even faster than would be expected by demographic trends. And so that's part of why this is not just something that's important now, but is becoming increasingly important every year.
Can you tell us a little bit more about that? You mentioned several kinds of interstitial lung diseases that exist. Are there some that are a little bit more common than others?
Yeah, for sure. I think in the ILD world, we sort of break things down into 4 categories. The most common is idiopathic pulmonary fibrosis. And this is really a disease where we can't find the reason why patients are getting scarring in the lungs. And, years ago, we used to think it was such a mystery, but over the last 10 to 20 years, we've more and more learned that this is something to do with people's DNA. There are certain genes and certain genetic mutations that cause some people to develop this scarring in the lungs. And that makes up about a quarter of the patients that we see in clinic. The second big category is autoimmune lung diseases. So diseases like lupus, scleroderma, rheumatoid arthritis, Sjogren's, mixed connective tissue disease. All of those conditions can cause both inflammation and scarring in the lungs as part of their syndrome. The next category is exposure related, and that sort of breaks into two groups. The first group of exposure related lung diseases are when people are exposed to organic matter. So the classic example is something called farmer's lung, where farmers will be exposed to some of the mold that's in the hay and other animal products that are in the farm. And as they breathe it in, that causes inflammation and scarring in the lungs. And then finally, it's the last group is inorganic exposures. So things like asbestos, and people mostly will be familiar with asbestosis. This is a condition where if you install or remove asbestos, you can get scarring in the lungs decades later. But there are other inorganic exposures as well, like mining and sandblasting. And to be honest, these days, one of the biggest causes of these inorganic dusts are people who install granite countertops, because there's a lot of silica in there and they can get silicosis almost like miners used to 100 years ago.
That's interesting information about risk factors. Can you tell us a bit more about who is at most risk of developing an interstitial lung disease?
Yeah, so I think it really depends on which type of disease we're talking about. So for IPF, the most common disease, that's really an age-related thing. So we know that the older people get, the more likely they are to get IPF. This is really only a disease that happens to people who are over the age of 50, but with each decade of life, your risk goes up. But there are other risk factors for IPF as well, like a history of smoking and a family history. For connective tissue diseases or autoimmune lung diseases, it's really the presence of things like rheumatoid arthritis and other autoimmune diseases. And for the exposure related, it really has to do with what exposures you've had. So for the organic exposures like farmer's lung, it's, are you currently being exposed to those things? But for the inorganic exposures like silica dust or asbestos, we're even talking about exposures you might have had 20 or 30 years ago. So we need to even ask our patients about, jobs that they may have had working in construction as a summer job in high school. That might be relevant.
We're going to take just a short break and get right back to our conversation with Dr. Shane Shapera.
Lung Saskatchewan has long been associated with leadership in health professional continuing education. Once known as a conference, Inspired Breathing now represents Lung Saskatchewan's renewed commitment to providing continuing education events for healthcare professionals that are responsive, innovative, and centered around partnership. Inspired Breathing inspires innovation, alignment, and partnership in lung health professional education, leading in transforming care. Find out more at lungsask.ca.
Dr. Shapera, we just finished talking about risk factors for the development of interstitial lung diseases and some of the different types. Now, you mentioned PF-ILD. What exactly is PF-ILD?
PF-ILD isn't really a diagnosis. We think of PF-ILD more of like a disease behavior. So I mentioned that some patients will have inflammation in the lungs, some will have scarring, and some will have both. And so the PF-ILD stands for progressive fibrosing ILD, or now what we tend to call it is progressive pulmonary fibrosis, or PPF. And these are patients where it's really the scarring that is progressing over time and causing trouble for the patients.
Well, let's talk about confirming a diagnosis. And you made mention in the earlier part of your specific interest in interstitial lung diseases about coming to that diagnosis being very interesting. What kinds of tests would confirm something like ILD or even PF-ILD?
Yeah, so when we see a patient with ILD, we really spend a lot of our time doing a good history. It's really important that we ask about exposures, both past and present, symptoms of autoimmune disease, so if they have joint diseases or skin rashes. And then in addition to doing pulmonary function testing, some of the most important stuff is really what we see on the CT scan. So we'll do a CT scan to look for both inflammation and fibrosis. And then if we see that our patients are developing fibrosis, once we've already given them whatever therapies or removed them from whatever exposures, that's sort of when we will call it that our patient has PF-ILD or PPF, progressive pulmonary fibrosis.
Now, at what point in a patient journey would a referral to someone like yourself, a specialist like you, happen?
I think it really depends a lot on your local and regional availability of subspecialty clinics. So, in Ontario, where I work, there are 2 ILD centers in the whole province that are trying to manage all of these patients. And so, you know, a lot of what we ask is for our colleagues in the community who are really very knowledgeable and skilled to both diagnose and manage most patients. And so we feel like in Ontario, the role of an ILD center is really for those people where there's either a major diagnostic uncertainty, even after they've kind of gone through the workup by a local respirologist, or if there's some real uncertainty about what treatments we should be giving, whether we should be giving anti-inflammatory therapies or antifibrotic therapies. That's sort of where I feel like those are the 2 areas where our clinics can be the most help.
Well, we have a referral, we have the diagnosis. Now let's talk about some next steps. Can you tell us a bit more about treatments that are available, specifically for PF-ILD? Like what kinds of drugs, for example, are currently available?
So in the ILD world, as I mentioned, we sort of break things down into anti-inflammatories and antifibrotics. And so in the anti-inflammatory world, we can use drugs like prednisone, but in everybody, prednisone has lots of side effects, and we always worry about those side effects. But in some forms of ILD, like in IPF, we know that prednisone has actually been shown to be harmful. So we really need to break down whether or not our goal is to use anti-inflammatories or antifibrotics. And in IPF, we really focus entirely on antifibrotics. And there's 2 different drugs in that class in Canada. We've got a drug called nintedanib or Ofev, which is one antifibrotic, and the other one is called pirfenidone. It's now generic, so its brand name isn't used anymore. And these 2 drugs both can slow progression of the fibrosis. They don't actually improve lung scarring, and they don't make patients feel better, but they can slow down the rate that the fibrosis gets worse. On the other category, when we see a lot of inflammation, we sometimes use prednisone, but we'll often use drugs like mycophenolate and even drugs like rituximab and tocilizumab and, the armamentarium of disease-modifying rheumatic drugs is really all the drugs that we have in our arsenal.
Can you share with us a little bit of information about the non-drug therapies? What other kinds of treatment options are out there for people with PF-ILD?
Yeah, I'm so glad you brought this up because, we always think as doctors and healthcare providers that what we want to do is just slap our patients on drugs. And there's no doubt that some of the advances in drug treatment in ILD have really changed the landscape. But at the same time, some of our non-pharmacologic therapies are just important or maybe even more important than some of the drugs that we have. And so, obviously our patients who are all at higher risk of getting lung infections when their lungs are compromised by their disease, we really strongly recommend getting vaccines. And whether that's an annual influenza vaccine, whether it's COVID-19 vaccines, RSV vaccines, or pneumococcal vaccines, we really want to make sure all of our patients' vaccines are updated. We want to encourage them to be active. I sort of say to my patients all the time, if you don't use it, you lose it. So the more they move, the more active they are, the stronger they'll be. And that's really important. And then often we will refer our patients to a pulmonary rehab program so that they can exercise and get more physically fit. We want to focus on mental health because, unfortunately, it's thought that somewhere between 25 to 50% of patients with ILD not only will they have these symptoms, but the 25 to 50% of our patients will actually have things like depression and anxiety related to their underlying disease. And so we want to identify and treat those. We give supplemental oxygen if our patients have exertional hypoxemia, and particularly if they have resting hypoxemia. We think about things like symptom management. So if we use them carefully, drugs like morphine and other opioids can really help with symptoms of cough, but they have to be adjusted and started at a low dose and adjusted up slowly. And then finally, we can think about things like lung transplant.
I'm glad you mentioned lung transplantation. There's lots of questions and curiosity around that. So with your specialty and your experience with the Toronto Lung Transplant Program, is this an option for those with PF-ILD? And if so, when does it become an option?
And so transplant is an option for patients who are otherwise relatively healthy. You don't have to be perfect, but you have to otherwise be relatively healthy with severe progressive lung disease. And this is actually a very common reason to get a lung transplant. In fact, currently, interstitial lung diseases are the most common reason to need a lung transplant. And in the Toronto program, which is actually one of the largest lung transplant programs in the world, interstitial lung diseases currently make up about 60% of the lung transplant recipients in Toronto. As far as when to start thinking about lung transplant, I usually say that if you're otherwise relatively healthy, the time to start to think about lung transplant is around the time that you get started on oxygen. Of course, the exact timing depends on local availability and local wait times, but that's usually when it's time to start thinking about, for patients, thinking about transplant, and for healthcare providers, start thinking about referring patients. Having said that, as much as lung transplant is a really exciting option for our patients, the lungs are unfortunately one of the most difficult organs to transplant. And so, even though lung transplant can be, for the right person at the right time, it's a miracle. I sort of say to my patients that it's not really a cure per se. Lung transplant is really a trade. You're trading one horrible disease that will cause lung failure and death if we just sit back and do nothing. You're trading that for lung transplant, which is a different condition where you'll have to take medications for the rest of your life. You'll need to be monitored forever. And unfortunately, lung transplants don't last for years and decades. But in general, we'll say that lung transplant for our patients leads to both increased quality of life and increased quantity of life when you start to get ILD that makes you that sick.
Well, Dr. Shapera, we're getting to the end of our time together, and we want you to think forward and help us see what the horizon holds. Talk to us a little bit about where the research is going right now for PF-ILD and ILDs.
So I will say that this is an enormously exciting time in the world of ILD. These antifibrotic drugs that I mentioned, they first came to market in Canada in 2014. And really, in the world of ILD, we've had a few small incremental gains since then, but that was really a paradigm shift. And that was about 10 years ago. But I am happy to say that, there are lots of new therapies and new learning. And these new therapies, some of them are really in the latest stages of development. And I think most of us who are in the sphere are highly optimistic that even within the next year or two, we are almost certainly going to get some new therapies that are going to get approved by Health Canada to treat various forms of fibrotic interstitial lung disease. So, I think it's a really exciting time. Having said that, my patients are really sick and they need treatments now. So my feeling is that these treatments can't come fast enough.
Dr. Shapera, just a sincere thanks for making time to talk with us on today's episode of Lung Lessons. We appreciate you and the important work you are leading with those suffering from fibrotic lung diseases.
Thanks for listening. If you enjoyed this episode and you'd like to help support Lung Sask's Let's Talk Lungs podcast, please share it with others, post about it on social media, and leave a rating and review. Follow Lung Sask on Instagram @Lung Sask and on X @Lung Sask. That's all for this episode. See you next time.
Produced at
Sound Lounge by T-Bone.